So his heart's big and floppy. I said, they're going to keep trying you on medications till we find the medications that work for you. I drew him pictures of what's happening with a patient who has a blockage. I drew a picture of what's happening with the heart, all this kind of stuff. And then finally he looked at me and he said, oh my God, I almost died. Yeah, almost. I said, but now you got a chance to turn it around kind of thing. This is what you got to do. This is why they're doing this kind of thing. He said, oh, I think I need to stay then. I said, I think you need to. I said, unless you got enough money to fly to, what's the hospital down there? The Bradenton Hospital. You gotta, this is what you gotta do. So he was like, okay, I'll stop. I'll stop now complaining about stuff, and this is what I'm gonna do. So he ended up being in the hospital another 10 days. He's there for a long time. So he goes home. He's gonna follow his doctor's orders, because I had students with him twice a week for 2 weeks. And then he goes home, and then we're off for summer break. So the nurses tell me, this man's been coming to look for me every week. I'm like, for what? Because I'm thinking, what did I do now? Kind of thing. But she said, no, it was the patient. I was like, still, what did I do to the patient? And she said, no, he was thanking you for something that you did for him. So he came and brought some stuff to the hospital for me, and I picked it up. And then I still didn't try to figure out nothing. So he waited till school started back and then came to see me while I was in the hospital. I was like, whoa. What? He said, no, I'm happy to be alive. Honestly, I am. So we go through this whole thing. Now the thing about it is, even though he's happy to be alive, he's still got problems. Why do I have to take this medicine? Because I feel good. I said, dude, take your medicine or you're going to die. Because some people you just have to tell them like that. So over the years, because now he's in his mid-40s, because that's how long he's been since I saw him as a patient. Sometimes he still does crazy stuff. And so he still has the heart rhythm that comes back really fast. He's been on Ticastin. He's had ablations. All this kind of stuff he's had done before. I told him he should have got an AICD a long time ago. And then I told him, I said, you should have had an AICD and fall out at work, because then you have your pension for the rest of your life. But he didn't want people to see that he had a device. Because if you wear a uniform, they can see. You know, because the pacemaker is, because that part of it you still see in somebody's chest. I said, well, I'd rather have a chick. What is wrong with you kind of thing? But people do what they do. So he ended up stopping working, what he liked, working at the sheriff's office. He works now still, doing something else. But I'm like, this is what, you know, that's the whole thing, because you went from being this healthy person to now having the heart of somebody who's 90 years old, essentially, because the way his heart was pumping, it was really that bad. Because even old people have better ejection fractions than that. Because if you look at some of your patients, most of them have 40s and 50s. There are some people you take care of having your 20s, because you will see that as we go along. Last week when I was in the hospital, because UT had clinical on Thursday, we had people that actually had, a couple of people had EFs in the 20s. So you'll see that. But that tells you the efficiency of the heart and the ability to pump is very low. And when you see that, that's a person who has no cardiac reserve. Heart rate goes up, they're passing out. So that's why low blood pressure, low pulse rate are things you're going to use for those patients. Different process by what happens, because it's a different disease entity that causes that in the patients, but the end result is a heart failure patient. The added piece about cardiomyopathy people is that whole issue about this does not get better for the most part. You can give meds, and so patients can have some improvement of symptoms, but the vast majority of people have some cardiac impairment for the rest of their life. 25% won't have anything, but the 75% will have some degree of impairment, with 25% of those people needing a transplant. Those are people that go home in a life vest, all that kind of stuff, until we can do some things with them. If they're really, really bad, that's the people that are on VADs, ventricular assist devices, that kind of stuff that you see in the hospital. Okay, but it's the worst case scenario when you're talking about patients having that. But there's no cure. So the only thing that you can do to cure it per se is to give a transplant. So that means somebody has to die for that to happen. So that's the issue. The medications that you give to the patient are what you do. You run that fine line between what's going to keep and quality of life kind of issues when you talk about the meds, because you got to figure out what works for the patient and what doesn't. So different process, but end result is the same kind of things you're looking for. All the medications are the same for the patient. All of that is still the same kind of stuff you're doing for them. So we talked about BNP. You might do a chest X-ray. that kind of thing. But the chest X-ray will tell you the size of the heart because you're actually able to see that if that's the person that you're worried about with cardiomyopathy. But those are the things you're going to see with that. Okay. Now the other things that are up here, because these are the ones you gotta, which I didn't talk about before, but I need to because they're important things. The concepts you gotta kind of understand and think about everything that happens with the heart. So preload, afterload contractility, these are the greatest determinants of cardiac output when you put them together, because they kind of work together as far as doing things with your patient. So preload is the amount of blood that's in the ventricle at the end of diastole before the next contraction of the heart. So if you think about preload, think about that's just what it is. Something is on board before you start doing something. So it's the amount of blood in the ventricle before the next contraction. So that's preload. So in your head, you're thinking about preload is what I have instead of something normally being there. So if the normal stroke volume, because that's the amount that's actually in there, the blood that's actually in there, is 50. Preload is increasing that. Okay, so if it's 50 that's supposed to be there, now there's 55. And the next year it's 60. And the next year it's 70. I'm just making hypotheticals, okay? But think about what's happening. That's Starling's law. If I stretch a muscle, because I'm adding more fluid to it, it's going to stretch out more. But if I keep stretching it, it's not going to make the forced contraction better. It will at the beginning, because it's compensatory at the beginning. But if you continue to let it go without treating it, it gets worse, so that you're not going to have good contractility after that. So preload is the amount of blood in the ventricle before the next heartbeat. Okay. Afterload is the pressure that the ventricle has to overcome to get blood out. So that's what you're pumping against. Because blood in the vascular system is under pressure, you got to push against it. So that's what makes hypertrophy in the ventricle if the blood pressure is high. Okay, so afterload is the pressure that the ventricle has to overcome to pump blood into the periphery. So contractility, of course, the easiest one up there. The contractile force of the heart. So the ability of the heart or the muscle to contract and then push blood along. So those are the greatest three determinants of cardiac output when you put them all together. Knowing where you are with that for the patient. Because that's going to affect patients who have heart failure. Because you're talking about the contractility of the heart. You find out how much blood is actually there. Can it push it along? Those are the things that you're looking at for those. So that's why those are important. So cardiac output is the amount of blood that's pumped by the ventricle in 1 minute. So that's stroke volume times heart rate. And then you got to think about this, the phases in the cardiac cycle. Think about what it was. Systole and diastole. Systole is when you have contraction of the myocardium. Diastole is relaxation. So when you're talking about blood pressure, systolic blood pressure is the pressure that exerted on arterial walls when the heart contracts. Diastole is going to be the residual pressure in the arterial system when the heart is resting. Okay, so those are things that you're looking at as far as your things that are happening with your patient. Systole and diastole are things that, because they're important to think about what should be happening in that cardiac cycle, that love dove kind of thing that's going on in the heart. Tells you when I should be looking for abnormalities that happen with your patient. And then, of course, when you have those extra sounds, because assessment piece-wise, there are some things that change based on what's happening with your patient. It is common to find an S3 in a patient who has heart failure. You may also see it in a child. So, but if I see it in somebody who's 70 years old, I know it's pathologic. It's not ever normal. 45 is not normal. If I got a 10-year-old, it might be physiologic. But in an adult patient, S3s are never normal. And you usually see it when a patient has heart failure. It can proceed shortness of breath. Just like the BNP can be positive before the patient gets short of breath, before you see a lot of edema, those things that you're looking at the patient for. That's why that's important. Assessment kind of things you're looking at for the patient. Okay. We talked about the cycle and what you have to look for. I mean, the other things that are here as far as the cardiac cycle goes. But knowing that when we look for patients who have problems, or if you're looking for pathology, it always guides. Think about what chamber, what area of the body is affected. It figures out or transcends to whatever the patient is complaining of when you see them in the hospital or care setting that you're taking care of them for. What you will see, no matter what disease entity diagnosis that the patient has, it always goes back to the same risk factors. Risk factor modification is going to be the same across the board, no matter what you do for the patient. Whether it be for heart failure, whether it be for heart disease, you're going to see the same things you have to monitor the patient for. Now, tomorrow, because I know how y'all like looking like that. All right? I already know when y'all told me, I was like, okay, girl, shut up. All right? But we're going to talk about the atherosclerosis piece tomorrow. So that's going to be that whole underlying process. So the overview is understand that there's a fatty streak that builds itself in the intima. When it attaches there, those fatty streaks are things you see as early as teenage years, because when kids die in their teenage, you can see the fatty streaks developing. Over time, as you eat more fat, because it's lovely, attaches there, kind of thing. Builds a matrix there until you get a blockage, because that's what happens. Plaque is forming in there. Think about the gunk inside a pipe. Essentially, that's what it is. Lipids go there, cholesterol, that kind of thing goes there, and the patient ends up having a blockage in the artery. Now, patients can end up having a 70% occlusion before they start having symptoms. Just know you can have some people at 25 and complain, and then you'll have people that have 70 and 80 that's not even complaining. So it's just going to be different based on the patient. All right? The people that live longer or that do better are actually older with this one. Because atherosclerosis actually builds collateral circulation, but that doesn't happen until later in life. That's why young men and women who have a heart attack die. You don't have anything that feeds the myocardium around there. There are going to be some changes that happen in your EKG that kind of tells me ischemia versus tissue death. So those are things we're going to look at tomorrow. But everything that we're going to look at tomorrow, unstable angina, acute MI, aneurysms, those all relate to understanding the atherosclerosis thing. Okay. Now, almost everybody's here. Not everybody's here. This was before some of you came to class. Friday, we as faculty had to meet back on campus to get together and see how we're going to address the issues related to missing days of school. The good thing for us is that we only had 1 week where we didn't have class. Most of the other classes, I think every other class, because they're doing class on Thursday, Friday, are missing 2 weeks of content. So they're like, trying to figure out what we're going to do. We, as MP4 people, got together and said how we can do these kind of things and look at how we can do the schedule. And our thought was that, of course, we would put another day somewhere that we would come back and do content. But like I said, if we do that, it'll be scheduled later in the semester. So somewhere in October that we would do that. So I'll give you plenty of time to hopefully schedule your life around that. The other thing we hope they do is get rid of all college day, because that would give us another class day. So we'll see what happens. We had got all our stuff figured out, what we were going to do, and then and we as a faculty met, wrote it down, got all our stuff together, and then before we left on Friday, they said, no, don't send anything out to your students. The college is coming out with an official statement about how they're going to handle these days. Part of it, I think, is because they have to make sure I don't think it's more of an issue with SACs. Well, it can be, especially for those people that have, you know, the stuff that you have to have, like English, all that kind of stuff, have to have so many hours. But the other thing, I think, has to be related to making sure every accrediting body is okay with time being missed from classes if you have to. So one of the things they were thinking about was getting rid of all college day, and then we schedule stuff outside of that. One of the other things they were talking about was actually extending the semester for another week. Whether that is going to be the case, I do not know. Now, the thing about it is, it wouldn't so much affect you, a lot of you, I mean, as far as, because you know how to do my class, we'll figure it out anyway. But what they might end up doing is, if that does happen, it would end up putting, we'll still do orientation day the same, but there may be some classes that have content on like November 2nd, or I think it is. Because I think orientation day is the 1st. So there may be classes that are trying to catch up their time on those 2 days, which would mean that those students would have to go to leadership later. Now, the thing about it is, I'm trying to still get through on our time schedule. That's just me, kind of thing. We'll see what happens. Other than all college day, or we may have another day outside of that, I'm not trying to make y'all go past December 12th. That's my thought process, okay? So we will see what happens. So hopefully either sometime later today, because I still haven't seen it this morning, that's why I was kind of looking at email to see whether or not they sent anything out about it. They haven't sent anything yet, but as soon as we know anything, I will put it up for the class what the address of that issue is going to be. Like I said, we're ahead. Every other class has not had one exam or a quiz. Yeah, so they're behind big time. And then they had 2 weeks off. So that's why they're panicking, kind of thing. All right. I know that's mean, but I'm like, whatever. I'm not even worried about it. So we'll figure out what all is going on. Yeah.
I had a couple questions. For Wednesday clinicals, for us to like go